Good evening, everyone, and welcome to the second part of our series on cannabis and pain that tonight takes the MDT format, which many of you working as health professionals will all be familiar with. The event is organised by CPASS, an independent and self-funded non-for-profit co-created by volunteers working to develop a better understanding of the role of cannabis in the patient's care pathway. A year ago, we launched our nurses arm at the Royal College of Nursing in London, with a mission to educate and support nurses so they in turn can better support patients who are using cannabis medicinally. These two cannabis and pain webinars are the first of what will be a year-long series of bi-monthly two-part sessions focusing on the use of cannabis in areas of medicine such as mental health, oncology and palliative care, neurology and women's health. We'd like these sessions to be as interactive as possible, so don't forget to make comments and ask questions through the chat box and the Q&A function. We'd also like to share the fantastic breaking news that today the United Nations has voted in favour of removing cannabis from the most restrictive Schedule 4 of the Single Convention of Narcotic Drugs, finally recognising that cannabis does indeed have therapeutic benefits. While this is in line with the UK's 2018 rescheduling of cannabis, it brings a much welcomed international seal of approval, which will hopefully remove some of the historic barriers to scientific research. We also hope it will help improve the situation in the UK, whereby approximately 900,000 patients are using cannabis to manage their chronic pain, with most turning to the black market. Even NICE acknowledges that chronic pain patients do not respond to the pain meds traditionally prescribed, such as opioids. However, they don't appear to have taken into account the experiences of almost 1 million patients who say cannabis manages their pain better than other prescribed medication and with far fewer side effects. Thankfully, we now have several extremely experienced pain consultants who are prescribing cannabis-based medicines to patients, one of whom is Dr. Anthony Ordman, whose clinical experience, alongside that of nurse Sophie Hayes, pharmacist Carl Hovey, and GP Leon Barron, we will be hearing today. Dr. Anthony Ordman, who many of you will remember from last week, is a senior full-time specialist consultant in pain medicine and medical director of Integro Medical Clinics. Anthony founded the pain management service at London's Royal Free Hospital in 1987, including the highly regarded chronic pain clinic. He also set up the Royal Free's acute pain service. Carl Hovey is an experienced clinical pharmacist and healthcare manager with extensive experience in the NHS, delivering direct patient care and managing services. He is the partnership director and chief pharmacist at Sapphire Medical Clinics and the private healthcare representative for NHS Digital's Expert Advisory Committee. Dr. Leon Barron is a practicing NHS GP, an executive committee member of the Medical Cannabis Clinic, and the founder of the Primary Care Cannabis Network, a growing group of UK general practitioners with a professional interest in medical cannabis. Last but not least, Sophie Hayes is a registered nurse working within the NHS. She is also CPASS Nurses Arm clinical lead and lead nurse at Integro Medical Clinics. Sophie is a specialist in emergency and acute medicine and has worked in A&E at the Royal Sussex County Hospital, in acute admissions at St Thomas's Hospital, and is currently working with the critical care units at King's College Hospital as part of a trauma course. When qualifying as a nurse in 2017, Sophie wrote her dissertation on the role of the nurse when working with patients using cannabis to manage their conditions. Sophie, over to you.
Thank you very much, Mary. Thank you everyone for joining us to learn more about cannabis medicines and how they sort of apply to your practice. I just want to touch quickly on the role of the nurse in the MDT and sort of why we need to be involved. And I think most nurses are familiar with the idea of an MDT and that you are a key component of any care team. But I just want to highlight a couple of key skills that nurses as a profession have that are specifically relevant to this area of medicine. So I mean, for a key reason is that part of our training is that we are taught to look at the whole patient as in all the facets of their life, and how that can be cared for effectively. And I've said this a number of times, I'm sure many other nurses have as well, that a doctor can make a very beautiful looking care plan for a patient that should in theory work, but if it doesn't fit with that patient's lifestyle, then they're not going to adhere to it, and it's not going to be effective. And we're a key part of that communication between patients and doctors. The other thing is worth saying that because of this skill set, it's particularly applicable to cannabis because of its multi-symptom management in nature as a drug. And you can actually manage a huge array of symptoms that affect that person's pain and affect that person's life. And as I said, the communication between the nurse and the patient is more regular, it might be more in depth. And for that reason, you can often, as a nurse, answer a lot of the questions that the clinical team might have about how best to move forward with treatment. And I would say, in terms of the reason we're looking at an MDT in this series, and putting cannabis medicines and patients that are prescribed them into this format, is that it's to highlight the applicability of cannabis medicines to your clinical practice, and that they're relevant to a huge number of areas that we've listed, Mary's kind of listed before now. So in that respect, it's important for us to help you learn how to better help more of your patients and use your skills to better support them. So I'm going to let Anthony lead with our case study, and we can start.
Well, thank you very much, Sophie. And just before I begin to present the case, what I'd like to say to everybody is that I'm very fortunate to be working with Sophie in this very level, multidisciplinary sort of way that Sophie's just been talking about. And indeed, I've been doing that when I set up the pain clinic at the Royal Free many, many years ago. It was multidisciplinary from day one. Everybody worked together with the patients. So not only does the patient benefit, and they love the fact that we're all working together for them, but we all learn and spark ideas off each other, and that's brilliant too. So our patient today is a 36-year-old woman who presented to our clinic with pelvic and bladder pain and genital region pain, which often exacerbated into what seemed like acute cystitis, including pain and bleeding on passing urine. All of this combined with nausea and so on. And she was fully investigated really for what seemed like to be repeated urinary infections. There were never any bacteria grown, and multiple courses of different antibiotics simply didn't help. In addition, she had abdominal bloating and pain, which sounded rather like IBS, irritable bowel syndrome, to us. All of these symptoms could be markedly exacerbated by anxiety and stress. And they had all begun around about the age of 15, when our patient tells us she had become sexually active. So a complete blank was drawn. The only positive finding had been on ultrasound, where the bladder wall appeared to be a bit thickened. But on cystoscopy, the lining of the bladder looked entirely normal, which tended to rule out diagnoses such as interstitial cystitis. So she'd been discharged by her urologist and was currently only under the care of her GP, who seemed very happy for us to become involved. Our patient had also tried homeopathic treatments and all sorts of other things. Despite a diagnosis of polycystic ovaries, which I think was found on the ultrasound, our patient has one daughter who's 3 years old, conceived after IVF. And at the moment, there are no current plans for more children, partly maybe because unfortunately the 3-year-old has complex medical difficulties, which are still undergoing investigation and treatment, all of which are understandably very, very distressing and worrying for our patient. She lives with her long-term partner, who I understand is supportive, and her little daughter, and they're near her own family, the parental family, who are also supportive. And our patients would like to work, but she can only manage 4 hours per week because of her painful and upsetting condition. Sleep is also very, very difficult because of anxiety. And despite her commitment to psychological methods and the Lingam method, and medications such as sertraline, an antidepressant, and medications like zopiclone and temazepam, sleep remains a real problem, 3 to 4 hours of disturbed sleep perhaps every night. Being around people is also very upsetting and difficult, and our patient tends to keep away from people she doesn't know or from crowds. And she's also very worried by people who are drinking alcohol. And this may hark back to unhappy experiences in childhood. So very understandably, our patient had resorted to getting her hands on cannabis, which she used in a medicinal sort of way, acquiring what she could at any particular time. She tried CBD tinctures, 3.2%, and THC paste, which, Sophie, I think she applied on the painful areas, if I have this correctly.
No, that's an orally ingested paste that she's tried.
There you are, team working, you see the benefit. And neither of these had helped. She tried vaporized cannabis flower of various sorts, which provided some relief, and there was a clue for us, of the pain and also the anxiety and sleep. So she'd found for herself that cannabis can be helpful if taken in the right way. She'd also tried edible products. So that really takes us up to the time that we met her. And I would add in this context that Sophie met her first. And I thought that was great. And then Sophie and I could discuss the case and think about it together. And then I met under current circumstances with a video conference as well with our patient. And after going over everything again and carefully noting that she had no plans for another child at the moment, because this is very important, we gave her 2 products, 2 pharmaceutical products. One was a cannabis oil. We feel that cannabis oils are the useful slow release substances that build up the therapeutic agents in the body. And the particular one we chose was a 1-to-2 sort of blend, 5 milligrams of THC to 10 milligrams of CBD, starting at low doses, despite the fact that she was not cannabis naive, at just 0.3 mils 3 times a day. But our patient was very insistent that she had a flower, and I can sort of understand why. And we agreed that to help her get to sleep at night, she would take an indica flower, which was 14% THC with minimal CBD, using this by vaporizer at night to help her get to sleep. And because everybody's safety is paramount here, she agreed that she would take this when her partner was already at home and available to look after their daughter. And that's where we started off. I think, Sophie, within about a week or so, we followed up with phone calls. And actually, if you think carefully about what she told us, she reported that day-to-day levels of background pain had improved to some extent, but these could still be aggravated by exercise and by sexual intercourse. And after discussion between Sophie and myself, we put the dose up still to a conservative 0.5 mil to try and progress things. So we followed up again, I think a couple of weeks later, and we heard that background pain levels were down from 8 out of 10 to 5 out of 10. And we all thought, well, this is jolly good. But we know from pain clinic experience that the patients don't notice slow improvements. They notice the acute ups and downs of pain, and so on. So we agreed that once there was another family member around to keep an eye on the child, she would use a second dose of flour by vaporizer in the afternoon, and would see how that goes. And I think she had found that actually of further benefit. So what we're reporting, probably after about 4 weeks of our patient using our prescriptions, what we're reporting on is work in progress. And we're finding out about how we should prescribe for this person, this individual person, in terms of which sorts of preparations, oil or flour, in what sort of doses and so on. And it raises this question that maybe our pure 1 or 2 substance extracts, oils, maybe are not as effective as flour with its more complicated mix of cannabis substances. And these are all learning curves for us at the moment, particularly with this sort of patient. But I think a good case to discuss, and I'm hoping that as well as interesting everybody else, we're going to learn and then tell her what we've found out, what we're going to do. Thank you.
Thank you, Anthony. I think one of the interesting things that I found when I first sort of came across this patient, among a number of things, but was as a patient first presenting to a clinic asking about cannabis medicines, that especially someone who has used cannabis before, to try and translate what they found useful into prescribable products, and to kind of think about what, when they say that the cannabis has been useful, what symptoms they found it useful for and at what time they've been using them. And it interested me that she said that she had tried edibles and that that was helpful, because it sort of insinuates that a long-acting cannabinoid release was beneficial to her, despite the fact that she repeatedly said that the flowers were something she would really like to be prescribed. I know, Carl, you're very experienced in prescribing the medications themselves, so I don't know what your initial thoughts were in terms of how this patient might have presented initially to yourself, and what actions you might have taken.
I think initially I would have had maybe ask a few questions about the background. So her mental state, was it pure anxiety? Did she have any other comorbidity, mental health problems, or suicidality, psychosis, depression? Anything?
So not in that extreme, so that sort of extreme, sort of the suicidal ideation has not been talked about. It's not something she's mentioned. She was very specific about anxiety and nightmares at night in terms of sleep. And so the sleep is disturbed by the pain, but also disturbed by that anxiety related nightmares. And when she talked about the anxiety in quite a lot of depth, it was about how she just had given up on trying to go out and see people. Obviously it's slightly different in the current circumstances that we're all in, but she would have generally have avoided socializing because it's just too stressful.
But low mood is not an issue for her?
No, it's not quite that. It's just very specifically this anxiety rather than depression. It's interesting you point that out.
Yeah, I'm pointing out because I think what we're finding is that where people do have a history of depression, and particularly if it's active depression, administering cannabis can actually lower people's mood, and we're finding that in quite a number of patients. So it's just making sure that that's been excluded, basically, or at least if it is a problem in the past, just keeping an eye on it when the reviews are happening.
Definitely. And I think that's one of the things to highlight, and it's one of the things that we've highlighted in part 1, was about the relationship between mental health and pain, and how to be aware of how you manage that with your care in combination with the cannabis medicines. Anthony, I don't know if you want to sort of reiterate a little bit for our audience about the relationship between mental health and pain, and how you've sort of learned how to manage cannabis medicines alongside that in the management of those patients.
Well, I think that Carl's absolutely right, that we must be very concerned about the mental health and the emotional health of our patients. It goes for all patients with pain, and indeed all patients, because we know that pain is just the physical sensation. Suffering is everything else that goes with it, the mood, the anxiety about what the pain means, what the effects of the pain will be, and so on. But we also know that the emotional state will regulate the pain as it's gated through the pain processing pathways through the spinal cord and the brain. It's all one big giant circle, and sleep is very much involved as well. Whereas 10 years ago, we felt that pain was preventing sleep, and therefore if you treated the pain, the sleep would get better. Now we realize that unless somebody gets a decent night's sleep and decent sleep physiology, then you can't really help them with the pain. So this is all bound up. We did not hear any suicidal ideation, and we didn't hear telltale signs of depression in terms of loss of self-worth or other features. And we didn't feel we had early morning awakening. We just had difficulty with sleep as a total. Nevertheless, our patient did prefer the THC elements of what we gave her. So maybe even without her picking things up, it did in some way make her feel better generally, and therefore notice the pain a bit less. But we do incorporate psychiatrists into our team for those patients where we do pick up elements of mental health concern. And very soon we're hoping that a psychologist or a psychiatrist will join us in our MDTs, so at least we can run these thoughts past our psychological colleagues and have an extra arm to what we have to offer.
And that's, I think that's a really interesting point about it's interesting what, Carl, you raised about, you're saying that sometimes you find that with the prescription of the cannabis that can lower the mood after post-prescription. What kind of situations or what kind of case studies have you found where that's been the case?
It's where people have had comorbidities of depression and anxiety, and we've treated them for anxiety. They've found that it dipped their mood, and we've had to stop it in a few patients because it really lowered their mood.
Carl, did you feel that it was any particular component of their prescription that was doing this?
I think it's the THC. THC really helped lower their mood.
Yeah.
Interesting.
Yeah.
Because I'm thinking that is it similar to, have you found it similar to antidepressants in the sense that when people are prescribed antidepressants, they're often told, it's going to get worse before it gets better? Do you think it's similar to that action?
No, I think with antidepressants, it's because it affects serotonin. Antidepressants cause that alerting. So when you're depressed, you have that negative cyclical thought pattern. Antidepressants give you a boost of serotonin. You've finally got energy to do it. So with antidepressants, with depression, you get the energy to act on those negative thoughts. So when younger adults are given antidepressants, they're the higher risk of suicide, and it's because they get the energy towards it. Antidepressants for anxiety, again, because it increases serotonin, increases anxiety. So you get like a worsening of anxiety in the first few weeks until things start to bed down, and then you get improvements using the antidepressant. So it's really different. It's like a really different presentation that you get from standard antidepressants for depression and anxiety as we're seeing with cannabis.
That's because I don't know, Leon, I know that's certainly interesting information to me as someone who might be following up with a patient post consultation, and in terms of things to look out for if a patient is being prescribed a medication that is having that effect. From a GP's perspective, in terms of was that something you're aware of, for example, or if that, I know secondary question to that, I think, is that when I know that there's a lot of fear from clinicians around mental health, cannabis, and that relationship, and how you might feel about that from your profession's perspective.
So, well, to answer your first question, no, I've not had any experience of seeing a patient whose mood has changed or been affected by cannabis scripts. That's really because I'm not working solely in the NHS at the moment. I'm not seeing patients that are attending private cannabis clinics. I'm sure there are now GPs dotted around the country that are perhaps picking up some of these side effects, perhaps, of some of these treatments. I'd like to think that the side effects are minimal, if not, are really quite rare, and that they'll probably be in contact with the prescribing specialists or the teams around them if there were any big problems. I guess as prescribing becomes more common and widespread, then yes, GPs will begin to be more involved with sort of looking after some of these overlapping symptoms. We've spoken before about the issuing of scripts. I think that's essentially going to be quite difficult, bridging the gap between private cannabis scripts and repeat prescriptions in NHS GP practices. That's not to say that will change in time, but I think for the foreseeable future, there's not. It's going to be quite a separate system, really, where the patients are looked after by their specialists and who are prescribing cannabis scripts, and people like yourselves, nurse practitioners, pharmacists, etc. Sorry, your second question, Sophie. Remind me.
Sorry, was surrounding the fear of clinicians around mental health and cannabis and how we've previously probably misconceived that relationship.
I mean, we know so much more than we did a few years ago. You know, in terms of mental health and cannabis, I think it's quite an easy for me now. It's, you know, if I have that conversation with a colleague, I feel you can navigate it. There's data now that shows that actually the highest risks individuals are those, particularly adolescents who have a strong family history of psychosis or mania, or anyone who's had an episode of psychosis or mania. There's a huge interest in psychiatry with high CBD oils and flowers, etc., because we know now that CBD has a antipsychotic effect. So I think that argument can be put to rest, actually. And if you look at the risk of psychosis around cannabis, then really the focus of that conversation should be on the street market and the high potency skunk that people use now. That's much more likely to cause a psychotic episode than anything that's being prescribed in a cannabis clinic. And actually, the prescribers in the more experienced prescribers in the US and in Israel, and I think probably now in other areas of Europe, are happily seeing patients who have had psychotic episodes, and some of them are even being managed by GPs. They feel very comfortable in issuing the right types of cannabis products for these patients. So I think it's a bit of an excuse now. I don't buy into that argument. I think it's a bit of a cop-out to use that as a reason. And actually, any GP or doctor that comes to it from that angle, I think they need to go back to the basics and relearn a few facts about cannabis, endocannabinoid system. And there are plenty of papers now out there that demonstrate that it's not the risk that we kind of once thought it was. That's my view.
Sapphire, with our mental health service, we're kind of seeing a fledgling change in the types of patients that we're getting referred, and an opening up of the views of mental health doctors in the UK, because we've seen a number of patients with tardive dyskinesia from antipsychotics who have psychotic illnesses who are coming to us to be treated for that, but having the support from their mental health team and actually referred by the psychiatric mental health teams, which is fantastic.
That's fantastic.
We've seen a number of people who, have had potential psychotic episodes in their past, but we're able to manage the risk with some of those. If people have got ongoing or new psychotic illness, that's not someone that we can see in our clinic at the moment because of the evidence base. But potentially there are, like you say, specific patients that we can see to treat them.
Yeah, I mean, just from my own personal experience, I'd say probably I've had more contact and discussions with psychiatrists than any other specialist. I think they've been very open-minded from the outset. And I think the position of the Royal College of Psychiatrists was very, very open-minded and open to learn more and try and integrate it more into practice. So no, I think, it's a good, it certainly has to be discussed, but I don't think it necessarily needs to be, overemphasized in that respect.
And am I right in thinking that most of our worries about inducing psychosis have really come from not from medicinal use of cannabinoids, but from street use during people are exposed to much higher levels of chemicals than we're dealing with here.
Absolutely. And also, some of the street products have synthetic cannabis within them, some spice, for example. And also the potency has been bred to be stronger over the last 20, 30 years. I think it's 3 or 4 times as strong as it was, in the 60s when people were smoking pot. And it's totally different how it used to be.
And I think what's interesting as well, the Maudsley in South London, they've started a project looking at harm minimization of high-risk patients with psychosis using street cannabis to give them Sativex. And I think that's so forward-thinking, and this is such a fantastic service that they're trialing. Like, it's brave new world.
Yeah, absolutely. And I think that is worth mentioning. Sorry, I had you guys inspired a thought in me, and then I totally. Oh no, I'm with you. Right. So Anthony, I was going to ask you about how you think the approach is in terms of how the potential prescribers might feel about the idea of approaching this multi-symptom management drug in the sense that that's quite unusual to how we're normally used to prescribing and managing medications and managing patients. So in terms of a newer prescriber, what would you think is people's thoughts or maybe apprehensions about it?
Yeah, I think in Western medicine, the culture is that we're thinking about one molecule and one response in the body. That's what science is. And, you can understand that. You've got to be able to measure things and have some idea of what you're trying to do and what you're actually doing. But I think coming from a background of pain management, we're already thinking very much in terms of the whole person and the complexity of the whole person. And we've already spoken this evening about the mind and the body and the interactions. So, and then we need to remember that in conventional Western medicine, it's not as purist as you might think. Think of all the different uses of aspirin. It was a painkiller, but actually it stops you getting heart attacks. But actually it closes a patent ductus arteriosus, in neonates. So where's the purity in that? And I think what you have to realize that in evolution, it's been very sparing, and it's reused the same molecules and receptors in the body to do different things in different parts of the body. Think about the oxytocin, the chemical of love. No, it's the chemical of muscle contraction. No. So there we are. We can already see complexity built into the body and into actually how we do use drugs. And that goes for gabapentin and morphine and all these other things. So there's one answer to your question. The other answer is this. As I said last week, I do love the idea that there is, as we know, a natural endocannabinoid system, which seems to be there to bring things back to normal after particular bodily responses. And we do think that endocannabinoid system becomes unbalanced when there's been distress or pain or injury or inflammation. And that system regulates all sorts of things, including inflammation, pain processing, mood, and so on. So there are several systems that are already influenced by our cannabis medications. So end of argument. I think complexities into the I've sorted it, and into the system. The skill for us, and I see that somebody in the audience has asked, do we need a better understanding of the ratios of cannabinoids that we're giving for different conditions? I think that's a really helpful question, and we've already noticed that in this case today, that the real skill, the real art of medicine, which of course includes nursing and pharmacy, is to try and perceive, using yourself as the receptor, what does this patient's endocannabinoid system lack, and what ratio of substances, not only CBD and THC, but also maybe the terpenes and so on, can we best replace to rebalance this person? I will stop talking now.
That I think that leads us back, because I was going to maybe bring us a little bit back towards the case study, as you just mentioned, in terms of that question then, in terms of prescribable products appropriate for the management of this particular patient and her multitude of symptoms that cyclically worsen each other. Obviously, you know what Anthony and myself decided to describe. I think Carl or Leon, if you've got thoughts on what kind of products might have been applicable, or what you thought, what popped into your mind when you saw the case study yourselves.
Yes. So look, I mean, the first thing that I thought was you summarised her case beautifully and so concisely, but this is probably a few years of misery for this person.
Absolutely.
To
She's
end
been
up,
having these symptoms since she was 15.
There you go, longer. So, you know, I guess what you know, I can picture the GP consultations going around in circles, perhaps not finding a diagnosis, being referred to for various tests, and often they're futile, these sort of tests, but they have to be done to rule out, you know, any obvious causes or things that could be perhaps more easily treated. She possibly, you know, you mentioned she'd seen a urologist. None of these things are quick, and, you know, everyone will have a go at treating something. You make the point, Anthony, that we work in this system, we sort of have this systems approach, and it's the way we've all been trained. You know, it's the way that the NHS is set up. If I see a patient, I have to decide, you know, who do I refer to for this particular problem if I can't manage it myself? And, you know, is it a gastro problem? Is it a urologist problem, a gynae issue? And actually the pain clinic is not always a clear option initially. It's often further down the line when you've exhausted other treatments that you refer to a pain specialist. So you mentioned she's conceived with IVF. Well, that doesn't happen quickly. That's an extra turmoil and stress and financial and personal worries that are only going to exacerbate any underlying chronic pain symptoms. So look, you know, this is actually not an unusual case in that I can think of many patients that fit these kind of complex sort of symptoms. The other thought that I had was she's obviously at some point felt let down by possibly by her doctor and by her prescribed medication. She's gone to the street market, I can only assume, to source cannabis. Obviously that comes with risks and added anxiety often for people. It's not often a choice they wish they want to make. And it sounds like she explored different types of cannabis as well, edibles and tinctures, topicals. So it shows you there's a world out there that we don't really understand or know about as doctors, but our patients who we're looking out for and looking after, this is what they're doing, you know, to try and find some relief somewhere. So I think that's a huge subject, and that brings in all kinds of interesting discussions about why, you know, people have to resort to those sort of measures. But I think essentially the types of products now that can be offered through the clinics, such as the one that you're running, it offers hope for some people, because I think cannabis just seems to allow people to make that step through, I don't know, that next step forward, whether it's overcoming a mental block or some kind of, it's not only helping with pain, but it's helping with sleep and perhaps with mood and other things like that, getting people back into work. So I just think it's a wonderful tool, an additional tool that to have it in a prescribing toolbox. And I think it's fantastic that people are now able to access cannabis products. I mean, clearly there's a long way to go in wider access, but I think it's much needed, and it really kind of does address a lot of problems in both primary and secondary care. Sorry, that's a long answer.
No, that was a great answer. Carl, I can see you've got some thoughts there on the tip of your tongue.
Carl. So if I saw this prescription come in front of me as a pharmacist, what would I be thinking? So I think I'd check in the notes to make sure you've obviously, I'm sure you've done it, is good sleep hygiene techniques, making sure that she's well on board. You've excluded all those things to help her sleep. Also the PCOS, make sure that, you know, she's doing the things that you can do for lifestyle advice around that to help, because that obviously could be impacting on her anxiety and her sleep as well. So, you know, I'll put that aside because you were asking about the drugs. The thing I thought when I saw this prescription is I'm thinking about the dose, because the clinical evidence for anxiety is much higher doses of CBD. So you've got small amounts of THC, which is going to be helping her sleep and her anxiety, in her pain, but you might want to think about higher dose of CBD. So, and if you think about higher doses of CBD, you're thinking about cost then. And because you've prescribed a combination oil, that's potentially going to be more expensive than using it separately, because the cheapest oils available in the UK at the minute, you can, if you do it separately, it provides you the ability to adjust it better, and also it works out cheaper. And obviously these patients that come in to see us privately, that can be a big factor for a lot of our patients, especially, you know, we're in the early stages of treating people with cannabis, and the costs tend to be quite high. So, you know, thinking about that, because she's got an oil and dried cannabis as well, it's going to end up being a bit pricey. So, you know, looking at separating the oils, adjusting the CBD a bit more, it provides you that flexibility. So yeah, that's what.
Yeah, and I think what you're saying is extremely interesting. And we did go in CBD heavy with that sort of thing in mind. But interesting that the patient's telling us she wants the THC. She you know, that not only seems to lift her a little, but also to help her sleep, which is paradoxical when you think about conventional medicines, benzos and things. But we shouldn't entirely base.
So I think it's not uncommon with people that are using illicit, because if they're using a lot of THC, sometimes they're missing out that extra CBD that they need, and you know, they just don't know that how effective it is to add it in.
Well,
I think what's becoming apparent as well is the number of patients that are perhaps more expert at this stage than the doctors who are prescribing for them, or in some sense they feel they know more, because they may have, I mean, I've met some patients that have the most amazing knowledge of cannabis strains and genetics, and they're on forums, they've traveled across the globe, and, you know, they're real connoisseurs. Like, you know, it's remarkable. So so doctors and the medical profession as a whole are really playing catch up in some ways, but I don't necessarily see that as a problem. I think it's just worth noting, isn't it, that some people, I know some of the other prescribers in some of the other UK clinics, and they've said patients will come in and they'll sort of say, I want this product or this strain because I think it's going to work very well for me, and that's a barrier to perhaps prescribing or for the doctor-patient relationship as we know it. What are your experiences in that sense?
The patient, you're absolutely right. They know a lot more about quite a lot of it than we do. And so what we try and do, first of all, is to match their request as best we can as our starting point. What's wrong with that? Because building trust is incredibly important in a clinician-patient relationship. So we try and match their request and respect their knowledge and views and see where we get to. And then, but it's cannabis prescribing, in fact, most medicine prescribing is never just, here's the prescription, goodbye.
Yes, yeah.
It's adjusting according to response and adverse effect and beneficial effect.
Yeah.
So we start, that's our starting point, but then we see if we can tweak it to get it even better.
Yeah, I think it's because it raises that. Sorry.
Our psychiatrist.
Go for it.
Was a really nice way of putting it. He calls it with his patients, it's a shared experiment.
Yeah, like, okay.
Prescribing these medicines, you know, it's not certainly, and I know that the effective dose for severe depression is 150 and above, really easy, regardless of acetylation status. Whereas these medicines, we just don't have those exact dose ranges. We know roughly in a ballpark figure where to get the doses, but with every single patient that we're seeing so far, you know, it's supporting them to have the right titration regimen to find the regimen that's going to work for them to help with their range of symptoms. And that shared experiment is a really good way of like describing the relationship that we're having with our patients and the way that we're going forward and moving forward to provide care. It's quite nice.
No, sorry.
I wonder if just for a moment, we're here to talk about cannabis, and we are. But if we think about the conventional medicines that we might use in the pain clinic, whether it's morphine or gabapentin or a tricyclic, I think what you're saying, Carl, applies to those medicines as well. There is no correct dose of there is no correct dose of gabapentin. There may be in the British National Formulary, but in practice, you don't know till you try what dose the person's needing. But what I will say very much about cannabis medicines is that we had reduced this lady's background pain quite a lot without any perceived detriment to how she felt, or whether she could drive safely, or most importantly, look after her child. I'm pretty sure that if we were using the gabapentins and the morphines and the tricyclics, we would have taken something away from this lady and had negative effects. She would be sleepy, or she might be having an unbearably dry mouth, or she might be slurring her words slightly. We haven't done that with our cannabis medicines, but we've gained ground in reducing her pain and other symptoms. So we're doing quite well with our cannabis medicines.
Yeah, and it's interesting. I did a webinar recently with Sophie, and we had for Medical Cannabis Awareness Week, and we spoke to some patients about their experiences. And actually, there was one particular chap who had been using street cannabis for a long time and was sort of considered himself quite an expert in that sense. But when he went, he said the experience of going through a clinical pathway and being with a doctor who understood where he was coming from and supported him, and then providing a very clean product, that he said it just felt so different, the whole process and the whole experience. And obviously he was supported in a different way with he was seen in a different light amongst his family and his friends and everything. So it just medicalizes something which obviously has benefits. But, you know, he did make the point that the products were a different class to anything he'd used sort of on the street. Do you remember that, Sophie, that conversation?
Yeah, no, that was a really good event, I think, and it sort of highlights the other aspects of I think that, Carl, what you've been saying, and Anthony, all of you have been saying, that is an interesting part, especially for professionals coming into this sort of new, is that idea of that, what you said, Leon, about that changing of relationship with expert patients and doctors, and that change of relationship in terms of how you manage that patient, because these, like you say, some people are expert patients and they're coming with a good deal of knowledge. And what, Carl, you were saying, it sort of highlighted that as well, when you were saying, in the same vein, I would agree that if you prescribed a singular product, you would be able to monitor the effects of that product more accurately, and therefore be able to sort of titrate it as appropriate. But the combination of things makes it slightly more difficult to identify which one is working for what. However, in that respect, that we were initially thinking an oil for that exact reason, but I think the fact that the patient was quite adamant that she would benefit from a flower product raises exactly that question: how much, and this is a difficult question, I think, how much guidance do the patients need, how much patients do the clinicians need when you're managing that relationship? Because really, for example, some patients, when I've done their pre-assessments, have said, when I say how much illicit cannabis do you use on a daily basis, they'll say 1 gram, 2 grams a day. When I ask them if they use it with tobacco, and they say yes, then we walk ourselves through how tobacco interacts with cannabis, and how, when you're talking about cost, Carl, when you say people are saying, you know, I use tobacco to make my cannabis go further, and that actually you're saying that you may burn through more cannabis because you're combining it with nicotine and with tobacco. And actually, if you use that product, when you think you need more cannabis throughout that day, you may be having that craving for nicotine rather than cannabis, and that actually how much you think you use may not be accurate to how much, like you say, with these prescribable products, they're purer, you have exact doses, they might be more effective in smaller doses. And that's how you navigate that as a clinician, I think is really difficult. I don't know what everybody feels about that issue.
I think what some of the difficulties come is when people have come across they've been using illicit smoking and they want to move to oils, and they need to be advised about the differences between switching from smoking to oils, preparing people for the different effect. They don't get the high peaks and troughs from smoking as you would with oils. It's a slow burn. It takes weeks for the effect to build. People need to be prepared for that and cognizant that this is going to be different, because otherwise if their expectations aren't met within the first weeks, they feel that things have failed and it's not working. So I think ensuring that the appropriate counselling when you're starting it is so important to set expectations.
And you've got to say that, absolutely right. You've got to say it at the first encounter, second encounter, third encounter, and keep saying it, because it takes a long time, as well as for the cannabis to soak in, for that information to soak in. But I think it's important. Yeah, and there's the other element which we've been touching on. It's not only the cannabis, which in a way is a gentler medicine, but it's the interaction with the clinician that's important, that we accept the whole patient. And I think that in the pain clinic, when we were less experienced, we spent forever trying to improve the pain so that the sleep and anxiety could improve. But I think something that we're doing better in this setting is to listen to all of the patient's distress and address them all together, feeling that we have the license to do so because of the sort of medicine that we're using. And I think that the first time the patient hears this, I'm paraphrasing, I think, what Leon said, they feel such a sense of relief. I was having a video cons with a man who was telling me all about his back pain. But I found myself saying to him, look, I really, really understand about your back pain. But look, you're very, very anxious. You're very distressed. And I accept that. And I'm going to try and help you with that as well. And I think he was quite surprised. You don't always spell things out as clearly as that. I just felt I would, and I did. And I think he felt so relieved that for the first time people actually understood. And he didn't have to push the pain, didn't have to push the physical symptom as his distress. We could now talk about everything. And
well, it's sorry to cut you off, Anthony. What's become very apparent to me really is how it's you need to be a generalist to manage these any patient really in this context, because we're not talking about pain scores. We're talking about sleep and mood and quality of life and function. You need to have an understanding of why they're on that particular medication for that particular problem, and can we reduce that down or get you off that. So I think I've said this many times now, but I think the UK has gone in with the wrong approach really, with this view that only specialists can prescribe, and actually there's nothing wrong with the private sector and private clinics, but I think they've allowed this situation to appear, and that GPs are not being trained to prescribe or being involved in this conversation. NICE and NHS are essentially blocking any access, and I think it's a great shame, because the bulk of the consultations up and down the UK and day to day are happening between GPs and their patients, and I think a lot of people are being let down by poor prescribing and long referrals, long waiting times to see specialists. So yeah, I think you have to very much be a generalist and have take a holistic approach to patients. Clearly, you sound quite an expert in that, Anthony, with your experience in the pain clinic and your interest in mental health as well. And I think those are the sort of skills that we also need as GPs, because we have those interactions all the time with people, with our patients. So anyway, we'll see how it develops. I mean, I think it's going to evolve. The landscape's going to change, and it will become more accepted and more mainstream. It has to, really.
It's only been 2 years.
Exactly. Absolutely.
And it's up to us now in these settings to provide good evidence of benefit and safety.
Exactly.
Then it can all move along. But the point is the NHS just does not have the capacity at the moment. So in a way, you're being safeguarded.
No, I know. And actually, that there's interesting data and it adds to the evidence base, the prescribing experience. So it's no bad thing. I just think there's a wider conversation really. And I found that GPs, the whole, have not been that engaged really in this subject matter. And I think, you know, perhaps
I did a conference,
well,
it was over a year ago now, with the LMC, the
yeah.
LMC National Conference, and like I went as part of representing Sapphire, just to
What was your...
and so some of the things that I was told by the GPs, it was quite funny. Like there's such a range. Like some GPs said, "Oh, my patients don't use cannabis." Like, oh no, that's something I won't be dealing with. Oh, okay.
Yeah.
Where do you work? South London. Oh, right.
Oh yeah. I know, it's amazing. I'm interested as well, Anthony, what your experience has been amongst colleagues and your peers in the pain, within the pain specialties in the Royal London, or...
Yeah, I think we're all a bit po-faced at first when patients ask us about this. Doctors, unfortunately, we often feel a bit challenged when patients know more about things than we do. And I will confess that I've very much been on a personal journey in terms of prescribing cannabinoids, maybe for the last few years, starting with the Sativex, which you sort of could prescribe. But other doctors who we've invited to join us in our clinic have naturally, and I do understand this, felt terribly worried about their reputation and about their license from the General Medical Council. And the way we get round this is to be very, very aware of the regulations and the guidance. And the most useful guidance comes from NHS England, paradoxically, that it's aimed at the NHS for those special cases where CBMs may be used. But we in our clinic, which is a private clinic, take it as our guide, and we keep within its guidelines, and therefore we're safe in terms of reputation and in terms of the GMC. And I don't think the GMC would mind my saying that when I wrote to them saying I'm going to be doing this, I'm not joking, they wrote back and said, good luck.
No, I appreciate that. And actually, like, I mean, it's only been a couple of years, but there are more prescribers now. It's becoming more accepted, it's discussed. What's your experience, Carl? Are you finding that people are more accepting, or is it much the same? You still wearing the stigma badge? Are you having to defend your...
I think I rang a GP practice maybe a few weeks ago. And I spoke to a practice manager, and she was shouting at me because she thought that I was trying to sell her cannabis. Like, I was like, I don't want cannabis. I was like, okay, I'm just trying to speak to you about cannabis for one of your patients. Well, it's not appropriate. I'm like, okay, I'll just email you then. So just know. Like,
the same thing, is it?
Same thing. Even I went to an anaesthetist conference just before lockdown, and I had the same thing with the anaesthetist. I had a really great time actually speaking to anaesthetists all day, speaking to anaesthetists about cannabis. And it was kind of like similar to the GPs, like their patients didn't use it. You know, it's not a thing that they would ever ask about. So I think that piece with medics and pharmacists as well. Pharmacists, I've been trained in mental health to, say that cannabis is as part of my clerking for patients, it's part of the drug and alcohol question. It's not about, it doesn't reach anywhere near the past medical history or treatment. That for me, that coming into cannabis, that's totally new. I need to ask when I clerk people, why are you having cannabis? It's not you're illicitly using cannabis as part of my treatment history. And I just come back. I come from a job at Bart's where got a big admissions pharmacy team. I can guarantee none of them are doing this yet. It's a bit needed.
I think it's so interesting and almost reassuring to hear you all talk about those individual things, because I mean, even I'm aware of when I was sort of learning about cannabis and how I was actually fascinated by it and its applicability, but actually within my profession, within my practice, I still didn't feel like I could sort of talk about it in a way that it had to be, I have read this, or couldn't say I think, or this is what I understand. And I know that even we've even had patients during the clinic who are nurses who, despite the fact that they are going to be prescribed legal cannabis, they're so scared. They said, I think it's so difficult. They were like, where I work, there's just no possibility of me being able to medicate there. There's no, even if it's legal. And it's interesting that even, you know, we talk a lot about the stigma attached to it, and obviously patients experience it as well. But, and it is a barrier. I think more probably, would you, I mean, this might be an assumption, but would you argue that that fear of the stigma and losing your reputation might be more of a barrier to people learning and engaging with cannabis medicines than the fear around the science around it, or the not understanding it? Anthony, you're on mute.
My wife wishes she could do that as well to me. But I think you're absolutely right. You know, talking to colleagues, but they look very worried.
Yeah.
The science is science. We're used to doing science at medical school, but we're also told to behave and be careful. And this all seems dangerous. And I think it's not only regulatory, it's to do with the terrible reputation that cannabis as such was deliberately given in the United States after prohibition. There was a big thing to demonize cannabis, and we're still suffering actually from that, both as lay people and as professionals. And that's why we have to gently undo that harm.
Yeah, it's a shame it has, you know, we have to use the word cannabis in a way. If it was called anything else, it would just be,
Exactly, yeah.
you know, job done, let's get on with it. And, you know, it's hard to remove that stigma, isn't it? And I mean, I always find it quite refreshing to look beyond the UK and to see what's going on elsewhere. And every time I have a few wobbles about being so actively involved in talking about cannabis medicine and education, I think, you know, I chat to some of the prescribers in North America, or attend a webinar or event somewhere and hear about what's going on elsewhere. And I think that the UK is just actually a bit slow to come around to this. And we have a very conservative approach to medicine. I think that comes with great benefits. We do have an amazing healthcare system. We have some of the best research and output medical scientific knowledge in the world, really, and all these fantastic institutions, but it doesn't fit very well into that existing framework because of its unlicensed nature and its you know, perhaps perceived lack of evidence and so on. So it's tricky actually for it to be fully accepted, but I think it will become less stigmatized in time. And I suspect the products and the prescribing will become much more refined and targeted, and perhaps have a slightly more pharmaceutical feel to it many years down the line, you know.
We're part of the Society of Cannabis Clinicians in North America, and the discussions that we have, like they have like clinical MDTs, like exactly like this, every month. And the conversations that they have, they are so much more progressive. You know, you're looking at cultivars, you're looking at like cannabinoid profile. It's much more scientific, and it's on a different level that we're having in the UK. I mean, they don't really talk about stigma and, you know, what their colleagues think. It's much more developed. So I think being involved in those discussions helps my practice and my colleagues' practice. But also we can see there is, you know, a different level of practice that we need to aspire to, and to develop UK practice. And, you know, exactly things like this, having this MDT that we're having is a start of that. It's a fledgling start of a brand new branch of medicine that will like definitely grow. So
absolutely. And I think in that vein, to sort of reel it back, because this is fascinating and you can sort of go down so many rabbit holes, but in that respect, to bring it back to the case study in terms of the science and sort of in the spirit of educating people about like you say, the more in-depth discussions about what might be more applicable. What do people feel about, for this patient and the multitude of symptoms that she is experiencing, the products where you can prescribe a THC CBD ratio versus things like flowers and full spectrum oils in terms of management, maybe successes that you've had in practice that you found those products are more beneficial? Or do people feel that THC CBD specific ratios is the way forward or not? I'm going to go with Carl. Carl, do you want to answer that question?
Yeah, I don't think using ratios initially is a good idea. I think using separate oils to find the right dose is better, because if you start off with a ratio oil, you're kind of stuck, because you're stuck with a particular ratio. Whereas if you've done it separately initially, even for the first couple of months, you've got that flexibility of finding which dose that you need. I think things with like epilepsy, you definitely know that you need much higher CBD. You know, you probably need a 300 to 1 ratio or something like that, or 300 to 5. But, you know, for epilepsy, we know much more refined exactly the ratio we need. But for a lot of indications, the clinical evidence doesn't give us a refined dose of CBD and THC that we need to titrate it to. So I think, I think once you've got a stable dose of CBD and THC that you've got found for a patient that works for them, I think then switching to a ratio oil that kind of fits their needs later on, seems more practicable, because you found exactly the right dose that works, and then it's more convenient to have it in an oil that's got the right ratio. I mean, it does mean you're switching to potentially a different product, but if you've got a strain that's available as the separate CBD and THC, that's ideal, because then you know, you've got the same product that you could have made into a particular ratio as well. So I think that's what I think.
No, that's it. Because and this is a question that I've got, because I'm not fully because what I would struggle with is how to measure in any way other than sort of the patient's feedback how effective the idea of a full spectrum, or the flowers and all the different individual cannabinoids and terpenes have in managing the symptoms of that patient. And I find it difficult to measure in any other way the effectiveness of those other than that patient feedback. And I don't know how people would recommend managing that in terms of managing that patient.
Well, the other measure, there are all these formal measurement tools which we sort of use in pain clinics. All of us here who, you know, you can just tell by looking at somebody. Somebody limps in on one occasion into the pain clinic, and you give them something, and the next time they come in without their stick and they bounce along and sit down, they say, "Well, doctor, I'm no better." And you go, "Well, that's an interesting point of view, but look at how you just came in." And often you actually have to feed back to somebody what you've just seen as a measure of how they're actually doing, and they haven't noticed. And then you think, well, how are they going to react to that? Do they think I don't believe them? And very often people say, "Oh, do you really think so? Do you really think I'm better?" You go, "Yes." "Oh, thank you, doctor." So there are measures. We listen, absolutely we listen, but actually watching and observing function and feeding that back is another dimension that we can add, and we can often do. And with the video links, we can sort of do that as well. Patient's demeanor is very important.
I mean, the national recommendations are that we, you know, should use a patient registry, to collect the outcome data. So I think the data that we need on the different strains and different products will all be related to the outcomes we're finding for our patients. So, you know, whatever products that we're particularly using, we should, you know, follow that in a systematic way, using, you know, validated methods, because then we can pool that data to show which products are more effective, you know, using that data to progress things in the UK to, you know, give a greater access for medicines on the NHS and more breadth generally. So making sure that, you know, we've got that data to push things forward.
And I think that's why I asked, because I think in the interest of moving cannabis medicine as a field forward and accessibility forward, that these things do need to be measured. But I would probably say that would it be fair to say that we're still at that stage where we are waiting to see trends in order to sort of identify what's most successful medications, what are the most sort of applicable symptoms that are being managed? Do you think that's fair to say that we're still at that stage?
There's very little clinical evidence that says one particular broad spectrum or full spectrum product's better than another right now. So we're definitely at that collecting data stage, and I think everyone working in a clinic and in the industry is very keen to make sure that we're collecting data to push through knowledge on use of products, because that's that's more beneficial for us as clinicians using those medicines. We know which products that to use in particular indications, and that provides better care for patients, and more commissioners of medicines are going to be able to commission these products for their patients because they have the clinical evidence that it's going to be beneficial for patient populations.
Definitely. I think there's a couple of thank you for that, Carl. I think there's a really a couple more points that I feel that can be drawn out of this particular case study that I wanted to just touch on. One of them is Leon, I was conscious of what you said earlier about patients discussions that we've had before where patients felt let down, and it's sort of connected to what everyone has been talking about communication with your patient, how important that is, setting expectations and so on and so forth. But this patient, it's what is interesting to me and what this patient raises in terms of feeling let down, was she specifically sort of mentioned about being a female and experiencing pain in a sort of female specific area, and that actually discussing her pain in that area may have made male doctors or male physicians feel uncomfortable, and how that may have impacted care, or at least listening. I think there's evidence that when women present, certainly in A&E, for example, the evidence has been that women who report high levels of pain are not necessarily that the score that they might give for their pain is not taken at face value in the same way that a man presenting in A&E with the same pain is, because the cultural conception is that a male will be able to tolerate higher levels of pain. So it's an interesting, especially for this lady who felt let down in that, and she mentioned specifically that respect, and how people feel like that they might approach that, what people have heard about that, what people have experiences of sort of gendered pain. It's a pain seminar, so sort of to explore that issue a little bit, I think would be really interesting.
Yeah, no, it's a valid point. And, I think it's very much an individual experience with individual GPs, actually, because we should now, there should never be any assumptions made or stereotyping. And actually, I guess at the end of the day, then certain problems, some women will feel more comfortable seeing female GPs because they might feel they understand to a deeper level a particular problem. It works both ways, of course. Men come in often to see male GPs about their prostates or their prostatitis or
exactly.
So that's really probably just how it might always be in that sense. But I think a good doctor and a good GP would always listen to a patient and listen and manage symptoms and take them at face value, non-judgmental, of course. What I would like to also add is the uncertainty that exists at the moment around cannabis in general practice. So, this patient of yours, presumably she was referred by her GP, who sounded fairly understanding. But what's clear is that actually the response that individual people get from their doctors is not that predictable. And, we spoke about this, didn't we, again, on this recent, sorry everyone, with this recent webinar with some patients, but it was very interesting because, they said it's an unknown. Some GPs will come back with quite a negative comment, and it's not something they want to be involved with, or it's not a proper medicine. And others will turn around and say, it sounds wonderful. Where can I send you? Who can we refer you to? So I think that's a big problem that has to be addressed. And I think it's actually unacceptable for GPs to have a strong opinion about cannabis if it's coming from a place of ignorance. If they don't know enough about it, they shouldn't be transferring that ignorance onto their patient or creating stigma around it. Because for some people, such as the case that we've discussed, that could be the only medicine that someone's found to be effective. So I think that's a big issue that needs to be talked about, and clearly we've got a long way to go. But I think there needs to be almost like how can I put it? you know, a sort of set pathway that GPs can follow if they want to refer into a clinic or they want to have a discussion. And actually, there doesn't appear to be much information out there, which is partly what's driven, you know, the need for these groups that we're all involved with or that we're setting up, that we're trying to provide our own education for doctors, because the Royal College of GPs position at the moment is still, you know, it's outdated. It's 2 years old. It sort of says, you know, you need to manage your patient's expectations. It's not going to be an easy process. Access is going to be almost non-existent through the NHS. And that's kind of it. And I think that's unacceptable when people are talking about this. They're talking about CBD products that they're using. They're buying over the counter, left, right, and centre. It's happening. People are using it. So I think that's an area that needs to be explored further and developed further.
So you're going to see this patient again in clinic, Sophie and Anthony. So what, just out of interest then, so when you do your review next, what's going to be your like key things that you're going to keep on the table to review with your patient?
In terms of symptom management or medication?
Anything really.
So in our most recent conversation, one of the things that she mentioned was she did have like an acute cystitis, so sort of symptoms like episode, for example, following sexual intercourse. And I think that, and it sort of relates back to what I was raising about women's health and pain, and sort of how we can sort of help cannabis help that, because I wondered whether or not, because the urologists haven't found anything in particular that's wrong, and I understand that for me that's sort of a little bit of a red flag surrounding pelvic inflammatory disease, and that whether or not that's been investigated, and she said that it hadn't. So whether or not it would be worth exploring that with her GP, for example, in terms of investigation. Another thing that we talked about in terms of acute pain, and we talked about before about the idea of pain diary, and the idea that instead of sort of reactive prescribing, this is what I was communicating with her, was because she said, you know, I've had this acute pain episode and I need a stronger flower. And we sort of said, like you said, you know, it takes a long time to build up in your system these medications and to find that everyday benefit. And so instead of this reactive prescribing and saying, you know, we'll prescribe this stronger flower, that I said, you know, can you record like how often you're having these acute pain episodes in a month? How long do they last? Do they come on are they triggered by anything in particular? Which do you need is the flower that you're currently prescribed helpful? Do you need a stronger flower? Is it just that you need a short-acting flower in that moment, and is that one sufficient? For me, it's sort of trying to get her pain under control, because it is an inflammatory response, but it's also we are sort of, she seems to be relatively happy with how the symptoms of anxiety and sleep are being managed, and that obviously the management of those has sort of supported better pain management, but the pain's still there. And I know we often talk about cannabis prescribing in pain, and that patients refer to, you know, no pain medication eradicates pain. That's just a fact. But what patients describe is that it's pushed to the back of their mind. It's not as overwhelming, and it allows them to sort of live life. And it's sort of the argument of cannabis prescribing to support quality of life factors. So for me, this is where, you know, and for me, this is where the difficulty is coming for this particular patient is pain management. Do you increase the dose of the existing prescription? Do you move them onto, you know, when she talks about edibles, that means that the flowers that, you know, illicitly she was using, I think the average estimation of average THC content of street market is like 26% THC, and none of the products that, you know, from the people we've prescribed for, and I don't know if you found the same, Carl, is that 22% THC is even sometimes too high and not necessary. So she obviously found benefit from long-acting high THC edibles illicitly, and whether or not the oil is a sufficient amount of THC, whether it needs to be increased in dose, or whether the product itself needs to be changed. That's sort of the questions in my mind about moving forward with this particular patient. Anthony, what would your sort of feelings be?
In terms of substances, I would sort of like to go in two directions at once. We don't really know what's going on at the mucosa, at the lining of the urinary system, but it sounds inflammatory, even though we can't see any inflammation. So my feeling is to persuade her to build up the CBD, probably through the oils, as you say, they're slow acting, to really get at what we think may be an inflammatory process that conventional medicine hasn't spotted. At the same time, I wonder what it is about the flower that's so helpful for her. Maybe it's partly the THC, but partly maybe the entourage effect, where there's a whole lot of terpenes and other things floating around, which she tells us she appreciates. So I think, and I'll be very interested to hear what Carl says, who so innocently asked the question. Really, I think we need to go more complex and more dirty in the extract of cannabis that we're giving her to try and help her with the pain.
Has anyone considered pessaries?
Well, that's what I thought what she was doing with the gel, but I was wrong. Yeah,
because I suspect, you know, in the US, Canada, they would probably be thinking along those lines at some point. I
don't think that those products are.
They're not here, are they?
In the UK. No, there's things like suppositories, like you said. The what did you refer?
Pessary, yeah, suppository.
Yeah, thank you. And then patches are also not yet available. We've got, I think, as far as I'm aware, there's one place that does gel capsules, but they keep saying they're not ready yet, and it's sort of, so we're very restricted in this respect at this point, in flowers or oils in the sort of array that they come in. Because I would have totally agreed to sort of target the pain management in that particular area would be ideal, really.
And you can get a cream and an ointment now in the UK.
Yeah. So do you think that would be applicable? Because that's sort of surface management, isn't it?
I think the dose is a bit higher with pessaries, so I'm not sure you'd be able to I'm not like the strength of the oils, would they be too greasy as well to administer?
Yeah, no, I'm with you. This is why we've brought her to you. This is why ideally we would have managed in all these. Every one of us can think of the ideal, and this is another one of the issues of cannabis medicines and pain is, in the ideal, these are the things that we automatically think of as sort of problem solving, and we are in a position where we're working in an environment where, you know, and pain is very similar, I've learned, and with the NICE guidelines sort of reducing the amount of options that are available to pain clinicians, what you're doing, and GPs as well. I think I talk about this all the time in terms of patients. GPs get a very bad rap from patients because they keep saying, you know, I only got 10 minutes with the doctor, they gave me a prescription, they sent me away, it wasn't helpful. And you're like, I think that you need to understand that a GP wants to help you, and they have, you know, in that 10 minutes, you'll come to them and tell them that you are in agony all the time and you want to kill yourself. This is like suicidal ideation. And in those 10 minutes, you've got 10 minutes to go, solve it, help me. And you're desperate to do so. So you give them what you've got. And I think this is the same in cannabis and pain, where you're sort of working in a relatively limited capacity in terms of what you have to offer. How do people feel about that?
I'm just going to kind of pop back in. I've been sort of away from things because this is so amazing. This is absolutely brilliant. But I've just got a few questions that I just wanted to kind of touch on. So Solomon Sheriff says, what can be done to ensure more doctors and allied health care professionals are educated in the endocannabinoid system? And do you think that the education of doctors and allied healthcare professionals can have a significant impact on the number of prescriptions being written for cannabis-based medicinal products?
There's a real need for education. And I think the way it's going to happen is for us, the cannabis prescribing population, to provide very, very brief one-sided A4 information documents aimed at doctors. How do we smuggle them in under the radar? And the answer is you give them to the specialist patient groups. So when they go to their next appointment in the NHS, they say, look, I know you don't know much about cannabis medicines. Would you have a look at this, please? And I think that'll, if it's the right style, it'll intrigue the doctors who will then want to know more. If it's phrased in the right way for doctors, then they won't be upset or worried about it. That's the way in.
My view is that we need universities, or one university, to become involved, and I've been trying to chip away at this for a while now, and I've had some quite interesting and productive conversations with some quite well-known establishments, and for whatever reason, we're still not quite there with it yet. But I think not just GPs, everyone, every doctor, every nurse and pharmacist, we need resources that we trust and that we feel are on par with the other types of postgraduate learning that we do. So if, as a GP, if you want to become a specialist have a special interest in a particular area, you might go and do a postgraduate diploma or even a master's course, or something less heavy than that. But I think there's a strong need for a national accreditation where you become, you have to do a set of modules and perhaps a short exam, and then you can become a cannabis prescriber. And I don't see why that should be different to any other type of learning that we do as doctors. The evidence is there. We just have to collaborate and work collectively and produce the content. And actually, there is some good material out there, but most of it comes indirectly from licensed producers or from commercial entities. And actually, the content, there's nothing wrong with the subject matter. It's very good often, but it's not coming from a place that we're used to learning from. And that's my view until we manage to partner with, we have the backing of a university or NHS. I know they've done the e-learning, the NHS, but it's pretty, it's not quite up to scratch in my opinion, but it's a good start. But I think it just has to be treated in the same way as any other type of learning that we do. And at the moment, it's just not quite there, but I think it will come with time. And we're all sort of collectively trying to improve what's out there. But I think there is a general lack of resources. Does everyone agree? Or?
Yeah,
I was probably one of the only professionals. I had endocannabinoid training and cannabis training in university in the 90s.
Wow.
So I think my university was the School of Pharmacy in London, and it was so progressive. We did drugs and like cannabis, and so I think it's quite a rare breed to have it such a long time ago. But absolutely agree that it the education. But I think there's such a need for it. We're a long way off delivering the volume and change that we need with professionals at the minute. At the minute, it's going to be driven by patients, and having accessible information for them is paramount.
Will the UN recommendation, sorry, Sophie, just because I'm wondering where this will kind of tie in, the kind of big news today that it's out of Schedule 4, and the recognition that it has this therapeutic benefit. Will that make it more likely to be included in education, or change the opinions of skeptical doctors?
I mean, from my understanding of it, it's a fantastic move forward. I think probably my initial reaction when I heard it was that what it will do is allow greater access for researchers in terms of creating evidence and making it as a substance less forms to fill out as a researcher trying to get a hold of the product in order to test it. And that was my first reaction when I heard the news from today. So I think in that respect, that's probably what that means for today.
Okay, I mean, it does seem to be the kind of getting rid of the barriers to research, which ultimately, we will therefore get the evidence, right? Hopefully, that's what will become possible. I'm just interested with this particular case study, whether you've been able to reduce any other medication that she was on since she started on cannabis-based medicines, and opening that up then into this kind of cannabis versus polypharmacy area, because there does, particularly with chronic pain patients, they are generally prescribed a whole bunch of medications, many of which interact with each other, and all the kind of various side effects, and it seems to be layer upon layer of medication that's prescribed. So starting off with this particular patient, have you managed to reduce any other meds that she has been on?
I think that's a very, very relevant question, Mary. And the standard advice, which I think is probably right, is that you don't reduce other medicines straight away. You wait until you've got recognizable benefit that your patient also recognizes before you reduce the others. And Sophie and I have had one or two other patients where they've, within a few days, quite significantly reduced their opioids and benefited from that. This young lady is a very sensible person, and she has actually taken herself off medicines, many of which she's tried, which she recognized were not helping. So the thrust of your question is absolutely right, although this lady is ahead of us all, and she's taken herself off them, realizing they don't help.
And Carl, because you're the pharmacist prescribing, or a prescribing pharmacist, so what's been your experience with patients at Sapphire?
I think we have had some success in removing polypharmacy for pain. Some patients have come to us from North America who are on extraordinary doses of OxyContin. I'm surprised they could walk. But we've been able to cut doses of opiates in people that are on pretty heavy doses, which is fantastic. And we've seen some success where it's improved their functional ability enormously, like reducing their level of opiate burden. So, I mean, it's been great in some of those patients. It's not been successful in every patient, obviously. And we've had cases of neuropathic pain where it hasn't worked and we haven't been able to bring down their pain. But where it's been effective and there's been significant burden, we've been able to provide some relief to those patients. I mean, it's early days as well for quite a lot of our patients. We've only been going a year. So, for those people that have been on it the longest, they're the ones that we've been able to help reduce their opiates, reduce some of their tricyclics and other medicines that have been used to treat for pain in the past that have been less effective and have been causing them problems.
I just wanted to share something. I have just oversharing, but I have have been the kind of in that cystitis cycle myself many times in the past, and there is a cycle with anxiety and cystitis. Particularly if it's kind of related to sexual intercourse, because you get terribly anxious before having sex, and then you get terribly anxious afterwards, sort of thinking, is the cystitis going to start, basically. So I'm wondering about, and this may be something that she's experimented with herself, about medicating before and after, just to try and deal with that anxiety around sex, which kind of in many cases does develop. I'm sorry for the overshare there.
I love the overshare. I think it's a really interesting point about that. I think that unfortunately for something like that, which would in an ideal world be a spontaneous act, might have to be for someone who experiences pain and has a chronic illness that is exacerbated by that. It might be worth approaching it in the same way you might approach going for a long walk, or for sort of prepping for your day, or going to work, because it is something that perhaps needs medical management. I like that idea. It's interesting that actually what you've said and what we've all talked about communication, that with this patient, until we'd had a conversation, she and I had a conversation about her symptoms and how they might relate to each other, that she said that no one had ever, which astounds me, no one had ever linked her pain symptoms with her mental health symptoms before. And that even with something as like common recurring UTIs, that feels like a very immediate link that you might make. But it's really interesting to me that no one had raised that with her before.
I think it's a very interesting response, but also what Mary may have been thinking of was the actual trauma of physical trauma of sex, and if we could lessen that by relaxation and so on, or the use of other substances locally as well. Yeah.
Carl, you looked poised to say something.
So what I think as well, that having these reviews with cannabis has allowed people who have suffered for a long time with symptoms to have that extra review and stop to review them holistically to find other issues or problems and making connections for their health. And I think about 30% of the people that we get seen for pain have been misdiagnosed, or their pain has some other cause or treatable issue, that's pretty high. That's
right.
Impressive. But same as this lady, like, you're finding connections. Could it be PID? Well, these fresh eyes have provided you with some other new treatment avenue, as well as the helping her with the cannabis for the pain. This extra review now has been on top by a different clinician to review her holistically. I think it's fantastic.
Well, I think also today we've had several extra eyes, reviewing this patient's case, and it's been amazing just to kind of, as a non health professional, to kind of observe what is an MDT meeting, and to see how the patient is at the center of this approach, and how hopefully we're modeling through these webinars, which hopefully is already happening in clinics, but what should be happening in the future, because as we've said many times, cannabis is just another medicine, right? It's just another tool in the toolkit for doctors and nurses. So it's I know the sort of team from CPASS are all delighted to be sort of having this groundbreaking format for talking about medical cannabis, with a focus on nurses. So thank you to all the panelists, to Anthony, to Leon, to Sophie, and to Carl. I'm just going to read a few bits and bobs that I've got to say at the end. Let me just find that. Well, actually, no, just before we get to the final bits and bobs from me, just a parting thoughts, really, your final thoughts. What would be your takeaway to members of your profession, if they are watching this, about using medicinal cannabis for patients with pain? So Anthony, starting with you.
I'm going to quote you: "It's just another medicine, number one. Number two, it's legal. And number three, it is much kinder to patients than many of the conventional medicines, which I'm sure are only there because of good marketing." There are 3 points.
Leon?
Very concise, Anthony. I'm trying to match that. Number one, drop the stigma. Drop the stigma. Number two, I would say, challenge the status quo in general practice. Don't just prescribe something because your colleague has been prescribing it for the last 10 years. Because what's evident is that we are creating problems for patients, and we're not necessarily acting in their best interests with some of the things that we're prescribing. And learn a little bit. Number three, learn a little bit about the endocannabinoid system, so you can have an informed conversation with your patient about CBD and cannabis.
Sophie?
I think, again, from a nursing perspective, that one of the things is to make you aware that it is relevant to your practice area. I know that when you feel like you've got 1,000 things going on and that there's no time, that we can shrink our sphere of relevance, and cannabis medicines and pain management are relevant to a huge number of areas in nursing practice. Number two would be to, again, agree with everyone else as to if it's interested in you, or if you've listened to this and you've had patients flash up before your eyes of all the people you've seen, and you thought, oh, I wish I'd have known this when we were managing them. Educate yourself about cannabis medicines and their applicability to your practice. And I think the final one would be, your nursing profession has a huge array of transferable skills. They have a huge array of in-depth knowledge, communication skills with their patients, to empower yourself to feel confident to recommend this as an option to your clinical team for your patients. I think that would be my takeaways.
Carl?
I think three things. I think, first of all, hospital pharmacists need to ensure that they're asking why patients are using cannabis when they're doing their clerking, rather than keeping it in the illicit substance section. And I think all pharmacists need to be aware of drug interactions. So cannabis is metabolized by the liver by 2C9, 219 and 3A4, which is significant, and there's lots of drugs that interact. And also they just need to educate themselves and use the resources that are available. E-learning for health is a really simple e-learning to get on board with, and Specialist Pharmacy Services has some really good information on cannabis and how it interacts with medicines. So there's some really good port of call to start their learning journey with cannabis.
That's brilliant. Well, thanks guys again. And just to say a little bit about CPASS, we are an organisation representing and supporting nurses. So if you are a nurse and you want to hear more, please contact us via our website or email nursesarm@CannPass. So that's can with two N's, CANNPASS.org. And please give us your feedback about tonight's session and what else you would like to see, either as part of this MDT series or other types of training. A survey link will be sent to attendees after the event, along with a list of resources for medical cannabis and pain, which will eventually be made available on our website. And to say a massive thank you to everyone who stayed with us. Amazingly, I think we've hardly lost anybody, because this has been like, you know, how long we're like an hour and 3/4 almost. So well done for sticking to the end. And yeah, and thanks guys.
Thank you.
Thank you very much for having us. Thank you.
Thank you very much.